So I just want to talk a little bit about acute respiratory failure and really what causes acute respiratory failure and how you define acute respiratory failure. And I want to talk about some just sort of general nursing assessment and some general nursing interventions. And then when we're in class, we're going to really look at very specific respiratory diseases that lead to acute respiratory failure. And then we're going to tackle ventilator-associated pneumonia and acute respiratory distress syndrome specifically in the classroom. So you really have to think about a little bit about what actually is the definition of respiratory failure, right? It's more than just, the patient stops breathing or the patient's failing to breathe, because it really has to do with whether the patient is becoming hypoxic or whether the patient's becoming hypercapnic or whether there's a combination of both phenomena happening. And respiratory failure can occur at any course during the course of any really illness, right? You can have, it can be the primary reason the patient actually comes to the hospital, or it's a consequence of something else, right? So the patient might actually present with respiratory failure because maybe they're having, asthma exacerbation, or maybe they've been in a traumatic car accident and had to be intubated, or maybe they're developing ARDS as a consequence of prolonged intubation. Either way, you have this state of altered gas exchange, and that's really what happens where the respiratory system fails, and it fails to either oxygenate the patient so the patient becomes hypoxic, or it fails to eliminate CO2 and the patient really becomes hypercapnic. And this is generally an acute phenomenon. Usually occurs over minutes to hours. There's really not a lot of time for compensation. There are patients who are chronically hypercapnic or chronically hypoxemic, right? But we're really talking about more of an acute state. Now, those patients with chronic hypercapnia, for example, those CO2 retainers that are COPDers who retain CO2 chronically, those patients can have an acute exacerbation and have an acute on chronic hypercapnic respiratory failure, right? And so those patients are going to get managed in a very different way than perhaps somebody who just simply becomes hypercapnic for a particular reason, okay? So type 1 failure is really the hypoxemic failure where there's failure to oxygenate. Both of these are really diagnosed from an arterial blood gas. So it's going to be really, really valuable for the nurse to advocate early to have an arterial blood gas, right? Your arterial blood gas is going to change before you really see any change in your O2 saturation. So O2 saturation, while a very valuable tool, is really not the best tool or not the best vital sign that we have to really diagnose this respiratory failure. So an ABG is going to be really important. And so if you did an ABG, you would see that the PaO2 is less than 60, and you have somewhat of a normal or low PCO2, then that is really how you diagnose hypoxemic respiratory failure. Type 2 is really hypercapnic, where you fail to ventilate. Your CO2 rises when you fail to ventilate, right? When you're not blowing CO2 off. And so you're going to see on your arterial blood gas that your PaCO2 is greater than 50. And when your CO2 rises, that really is going to drive your pH down to an acidotic state. And you look, and it really produces a true respiratory acidosis. The patient may also have hypoxemia as well, depending on, how complicated the disease. And there's so many things that cause respiratory failure, right? You have exacerbation of chronic respiratory disease, right? You have asthma, you have patients with COPD, patients with sarcoidosis, so many chronic respiratory illnesses. You can have pneumonia, you have trauma, you have sepsis, you have medications that cause respiratory depression, you have central nervous system diseases, you have alcohol intoxication. There's so many reasons why patients really are at risk for respiratory failure, okay? So when you tackle respiratory failure, it's going to be really important to really differentiate, is this a hypoxemic problem, or is this really a ventilatory problem and the patient is really hypercapnic? Because the interventions that the nurse really needs to do in the acute setting is different depending on what the problem really is, right? So it's really important when you're thinking about respiratory failure that you're really thinking about your pathophysiology of what is happening inside the patient's body, right? Because when your interventions fail to produce a positive response, you have to be able to step back and say, all right, I've put oxygen on the patient, I've titrated this oxygen up, it's still not working, what am I missing, right? What's happening physiologically inside the patient that this oxygen is simply not helping? And the sooner we recognize these things, the better the outcome for the patient, right? So we kind of categorize it into reasons why we have failure to oxygenate and reasons why we have failure to ventilate. Although I will say hypoventilation and VQ mismatch are reasons to have both problems. And so frequently in an acute setting, you will have patients that unfortunately have sort of a mixed picture, right? So hypoventilation is very simple, right? It occurs when we breathe less than a normal tidal volume. So when we breathe in every minute, there's a certain amount of oxygen that enters each alveoli, and that's really what determines our alveolar ventilation. And so that's really determined by a couple of things, right? It's really determined by your tidal volume, right? So how much tidal volume do you bring into your lungs, right? 300 milliliters, 400 milliliters, 550, depends on a lot of things. It also depends on your respiratory rate, and it also depends on how much dead space there really is. Now, remember that the dead space is really from the tip of your mouth down actually into your alveoli. The bronchi have to fill with air in order to get air down into the alveoli, but the bronchi themselves do not participate in gas exchange. So about 150 milliliters of every breath we take fills the dead space first. But if the dead space increases, less air is going to get down into the alveoli, right? So you'll have to look at all three of those things, right? So a decrease in ventilation is going to cause a decrease in PaO2, which is really your arterial oxygen content, okay? So why do we hypoventilate or have a hypoventilation syndrome? There are so many reasons it could be. So many times with hypoventilation, we really have to just simply identify and fix the problem. So you can have drug overdoses, anything that causes central nervous system depression, neurologic disorders like myasthenia gravis exacerbations, anything that's going to cause a decrease in the rate or depth of respiration, like a spinal cord injury, thoracic surgery, like if there's a lot of pain on inspiration, people will simply hypoventilate, right? This is why a lot of our nursing interventions really focus on, incentive spirometry and getting patients to cough and deep breathe and getting patients up and moving and good pain control. And sometimes you'll see a rise in CO2 when there's less gas exchange as well, or when there's less, when you have like an increase in dead space or you have a decrease in respiratory rate, you will see a lot of times a rise in CO2 as well. So then you have sort of a mixed picture. Intrapulmonary shunting, another cause really for failure to oxygenate. Normally we have a small physiologic shunt. That's where a small amount of blood returns to the left side of the heart after it leaves the lungs, and that does not really participate in gas exchange. So if you think about, incrementally, if there's a little bit of blood leaving the lungs that doesn't actually get oxygenated, then you have a shunt. Well, if that shunt becomes worse, then you have a larger amount of blood leaving the lungs whose hemoglobin are not saturated with oxygen, right? So there's failure to oxygenate in that respect. And that physiologic shunt then becomes pathologic, right? And so there's going to be this decrease in PaO2. And you see this when there's areas of the lungs that are just simply not getting oxygenated. But blood flow is fine. So there's flow past the alveoli just fine, but the alveoli themselves are empty. There's no gas in them, so there's no oxygen to exchange. So the blood just sort of drives on by these alveoli that simply are not filled with oxygen. So blood's never going to get oxygenated, so that means that when it returns, when it goes into the left side of the heart, there's no oxygen in there, right? So it's being shunted past the lungs. Now you see this when alveoli are collapsed, right? When you have atelectasis, say after surgery or after significant hypoventilation syndrome, you're going to have atelectasis. So we have to simply fix that, right? We have to get patients up and moving. We have to get them using the incentive spirometry. That's how we prevent an intrapulmonary shunt, right? So you have you have atelectasis. You can have areas of consolidation when you can have a very significant pneumonia. You can have the lungs that are filled with fluid, right, like in a state of heart failure exacerbation. You can also, though, have times when blood is simply going from the right side of the heart to the left side and it's bypassing the pulmonary circulation. You see that when you have atrial or ventricular septal defects, right? So as the shunt worsens, the PaO2 is going to continue to drop. So here, in this regard, you simply can't just give the patient oxygen, right? Oxygen's not really going to fix the main problem because the alveoli are collapsed, or the alveoli are full of pneumonia, or the alveoli, you're never going to get oxygen into those alveoli to begin with, right? So here, as you are putting oxygen on the patient, if you are seeing no result, you are seeing your patient's not really improving, your O2 sat is not improving, and you're titrating oxygen up, right? 2 liters, 4 liters, 6 liters, all of a sudden they're on a non-rebreather and they're still not really making improvement. You have to step back and say, are we really thinking about what the main problem is, right? Are we missing something? Because here, in order to fix oxygenation in this regard, you have to fix the underlying problem, right? Because there's just areas that are never getting oxygenated, right? So adding oxygen isn't going to help that. So you can also have a VQ mismatch. VQ mismatch, again, where there's an imbalance between ventilation and perfusion, right? So normally we have a balance between ventilation and perfusion around the alveoli, and that really creates like a ventilation, it just creates a ratio, and it's really a ratio of 1, like 1.0. And so what happens is when there's an increase in ventilation but not perfusion, or a decrease in perfusion, then you're going to have a VQ mismatch. You're going to have a mismatch between ventilation and perfusion, right? So if ventilation increases but perfusion does not, then you're going to have a mismatch, right? If ventilation decreases but blood flow is adequate, then the ratio decreases, right? So very common cause of respiratory failure and of hypoxemia. So it just really depends on what's causing the shunt, right? When ventilation, at a time when like ventilation is increasing but perfusion is not, is really at the time when you have a pulmonary embolus, right? So if you have a blockage in the arterial system, then the patient's going to start breathing faster, but they're never going to improve their oxygen level because there's no flow past the alveoli that are in fact full, right? So a VQ mismatch is something we have to really consider when our patients are, we're adding oxygen, but they're not responding to it, right? Their PaO2 is simply not going up. Their O2 sats are not going up. The patient is getting clinically worse, and we're trying to do all the right interventions. So we have to think about a VQ mismatch as the cause. So lots of things cause a VQ mismatch, and we'll talk more about that in class as well. Diffusion defects occur really at times when, this is where really your ARDS and your sepsis come into play. Diffusion occurs when gas moves from an area of higher concentration to an area of lower concentration, right? So in the lungs, this is the exchange of oxygen and CO2 as the gases move between the alveoli and the blood across capillary membranes, right? So again, the oxygen and CO2 are going to diffuse from one side to another, right? You have CO2 in the capillary, diffusing into the alveoli, exchanging for oxygen. Oxygen diffuses into the blood and hooks up with the hemoglobin, and then you exhale and the CO2 is expelled from your body, right? So that really is how the diffusion of CO2 and O2 really works, right? So there is a space between the alveolar lining and the capillary membrane. It's a very little space. It's just a little distance for the gas to actually travel. But if that space gets bigger, then it takes longer for diffusion to occur. And as that space gets bigger, if it takes longer, then you're going to wind up with a diffusion defect. Because what happens is gas starts to creep out of the alveoli, trying to get across this capillary membrane into the capillary, but the space is too wide, it never makes it. So hemoglobin drive on by and they never get oxygenated. So You see this at times when when you have atelectasis, right, where the space, right, let's say you have like atelectasis. Normally surfactant keeps the alveoli open. There's some interstitial fluid, right, but if there's a loss of surfactant and alveoli collapse, that increases the space. You can also have sepsis or ARDS, where you have an inflammatory process where that again causes so much capillary leaking, and that increases the space. So normally the exchange takes about 0.25 seconds, but if it takes longer, you're going to see usually you'll see hypoxia first, and then hypercapnia is a very late sign, right? So because CO2 is a little hardier and can diffuse a little easier than O2, so even though the space is wider, CO2 will make it to the alveoli and the patient will eventually exhale, but oxygen just kind of gets lost, and it does not diffuse as easy, right? You can also have other physiologic states that cause the patient to fail to oxygenate, right? Low cardiac output states. So in heart failure exacerbations, when you have less cardiac output, you have less oxygenated blood simply leaving the left ventricle, and so that's going to, of course, affect the whole body because you have less oxygen getting to the tissues. You can simply have low hemoglobin, right? Significant severe anemia, right? Hemoglobin, if you have a loss of hemoglobin carrying oxygen carrying capacity because you have low hemoglobin, you will have eventually a hypoxic state. And you can have tissue hypoxia from many reasons, right? Usually from shock. So you can have septic shock, you can have all kinds of different, hypovolemic shock. Whatever the cause, you have hypoxia simply at the tissue level. So many times when you sort of think about hypoxic respiratory failure or hypercapnic respiratory failure, really it is important to think about the cause, because a lot of times we have to fix the cause if we're going to help the patient. So our nursing interventions really kind of come into play when we think about how do we know our patients are hypoxic, right? If your first answer is really check an O2 sat, there are so many things that we are missing clinically before an O2 sat actually drops to show us that the patient is hypoxic, right? So if you remember, the first sign of hypoxia is always mental status changes, right? So we always start with neuro, right? So first sign of hypoxia is always restlessness and confusion. Can't always really rely on your numbers, so you really have to look at your patient, right? Restlessness, agitation, anxiety, confusion, progressing to a change in mental status where they become lethargic and somnolent, right? That occurs as CO2 rises. Again, neurostatus is so important, right? These are subtle changes that we frequently miss early on, but these really are the first changes that we see of patients as they become hypoxic. Now, the unfortunate reality is that a lot of times our patients are older, and so we tend to gravitate towards they have a little dementia, or they have a little they're normally confused at baseline. So this becomes this sort of clouds our judgment, I think, when we look for the neurologic compromise that we see early on, right? So we also listen to lung sounds, right? So, airway, breathing, circulation. So after our really good neuro exam, the respiratory system, we're going to see changes in the system. So breath sounds obviously are important, but it's more than just listening to lungs, right? Because we have to look at the depth and pattern of respiration. Are there periods of apnea? As we get hypoxic, what tends to happen is that patients get tachypnic. They start, right? If you remember, you have baroreceptors and chemoreceptors at the base of your carotids, right? Brain is, again, very sensitive to CO2 and oxygen. So those chemoreceptors at the base of the carotids are going to signal the brainstem to increase respiration, right? So if your body is becoming hypoxic, the natural response is that, you just must need to breathe faster. So you're going to typically see tachypnea first, and increases in sort of depth and increase in tidal volume. So you're going to see like the attempt of your body's compensatory response is to breathe faster and to maybe breathe deeper. So if you think about that, is what should happen as the respiratory rate goes down. That typically is an ominous sign, right? Patients start using accessory muscles, they start having sternal retractions, right? So that sort of reduction in respiratory rate and depth sometimes can be an ominous sign that patients are becoming hypercapnic. But we also have to look at more than just, the actual respiratory assessment. Does the patient cough? We can look at sputum. We do a chest x-ray. We look at pulmonary function tests. We look at our O2 our H&H. We look at blood gases. We can look at end-tidal CO2 monitoring, which can help us, look at, do we have actually hypercapnia, right? As we get older, we have to think about the older adult, harder for them to clear their airways, respiratory muscles get fatigue, decrease in cough reflex, right? Patients get kyphotic over time, so their chest wall may not move as well, right? So patients do have the older adult really is at risk for hypercapnia and hypoxia because of just their natural physiologic aging. Okay. We also look to our cardiac system. The heart will compensate to increase cardiac output to perfuse the tissues. That's what it does for us. So you're going to see tachycardia typically as a compensatory response to hypoxia, right? Because the body is trying to perfuse the vital organs, and that's really the brain and the kidneys. So tachycardia is going to hopefully produce an increase in cardiac output and increased blood pressure initially. But again, as respiratory failure progresses, you're going to see changes in heart rate and rhythm. And so what happens is the heart tends to become irregular. You tend to start seeing a lot of cardiac dysrhythmias, and patients can, of course, get bradycardic and eventually have a cardiac arrest. Now, the older adult, you have to be careful about because a lot of times they're on medications where they're beta blocked, right? So patients on calcium channel blockers and beta blockers, they may not have that compensatory response. So we have to take that into consideration. If we don't see tachycardia, does that mean that, they're okay? Typically, it's because there's a medication-induced blockage of that response, and so that then the patient's doesn't have that compensatory response, right? And so they may decline even a little bit quicker. And then we just sort of look at the overall patient, right? Look at their skin, looking for cyanosis, looking for pallor. Again, cyanosis is a very late sign of hypoxia, right? A lot of things are going to change physiologically before we see cyanosis. But when we see cyanosis, those are signs that perfusion is really an issue, right? So lots of things go into our nursing assessment. The last thing that really we want to goes into our nursing assessment is actually looking at the psychosocial needs of the patient, right? We do need to assess these early on. What does the patient want? Do they want to be intubated? Do they want to have, mechanical ventilation? Many times as patients are declining, it's harder for them to make those decisions, and family have a hard time making those decisions as well. But it is important for a nurse, us as nurses, that we really do advocate for patients, because if we're watching them decline, especially their respiratory status, and they don't want to be mechanically ventilated, because many times that really is the end, the big intervention that a lot of these patients are going to need. If they don't want that, we have to be able to advocate for them and make them comfortable. So it's really, really important that we sort of know what their wishes are and can help families, come to terms with the fact that this acute problem may not end well. So some general nursing interventions, and these things can really be applied to really any respiratory disease that we're talking about. Again, though, it really depends on, is this going to be the right thing for the patient, given the pathology of what's happening inside the patient's lungs. So, of course, we're always thinking airway, breathing, circulation. So the first thing to do is open the airway, right? You cannot expect to oxygenate the patient if their airway is not patent, right? So we have to maintain a patent airway. So how do we do that? Well, there's non-invasive and invasive methods, right? Which some of them you've probably already talked about by now. We have oral airways, right? We have nasal airways. Those are typically non-invasive. We have also CPAP and BiPAP. Those are great for patients with CHF and asthma and COPD. But there are always patients who need a more invasive method, and that is really mechanical ventilation. So, can we intervene early and give them a non-invasive airway? And maybe use some positive pressure ventilation before we have to actually intubate them. We want to maximize oxygen delivery, right? And we do that really with positioning. Sit these people up, right? High semi-Fowler to high Fowler, right? And if there's a unilateral lung disease, many times we say good lung down, right? So we can consider that. That really allows for perfusion, right? So positioning is really, really important in patients. And then actually giving them supplemental oxygen. So that could be nasal cannula, could be a face mask, right? Our goal is usually to maintain an O2 sat greater than 90, and that will help us maintain a PaO2 greater than 60, right? So never really going to get 100%, and if that's not effective after we've titrated some oxygen, if you're still not having a positive response, we need to consider that mechanical ventilation is what the next step is, right? So we also may need to give blood to the patient to optimize oxygen carrying capacity. We need to look at just optimizing the delivery of oxygen for a lot of reasons. Maybe they need fluid as well, and maybe they just need fluid or blood. So giving the patient oxygen is only one side of it. We also have to minimize their demand, right? If we're adding oxygen, but we are not reducing the demand, they're simply going to consume everything that we give them, and we're not actually helping, right? Or we're not actually going to make any progress. So we need to make sure that we're minimizing oxygen demand, and that's really by decreasing the patient's metabolic demand. So treat their fever, treat their pain, make sure that they're getting good rest. If they're agitated because they're on a vent, we need to sedate them. We need to make sure that our tubes are patent. We're hyperoxygenating them before suctioning, right? We have to actually give them, reduce that oxygen demand. That really will help. We need to treat the cause of the failure, right? All the specific interventions for whatever's causing the actual failure, right? Identify pneumonia early, for example. If we're missing pneumonia and they're not getting better, they're not getting antibiotics that are needed to treat the pneumonia. So we need to make sure that we really treat the cause of the failure as quickly as possible, which means we have to identify it. And then we want to prevent any further complications, right? Problems from immobility, fluid and electrolytes, right? So we have DVT prophylaxis. We have to worry about skin breakdown. We need to make sure they're not over-sedated or under-sedated. So if, for example, if you're on a ventilator and you're under-sedated, there's a risk of extubation there, right? Or there's a risk of pneumonia because you can have aspiration of secretions around the tube, right? So there's lots of complications that come from being intubated, right? So patients are at risk for, getting pneumonia in the hospital, which again is just going to add a whole nother layer of complexity to the patient, right? You come in with heart failure exacerbation, get intubated, end up with pneumonia. Not a good thing. Now you have a whole nother problem to deal with and manage, right? So we have to sort of look at sort of a bucket of interventions that we can do for the patient. And sometimes you have to do a lot of these things at the same time. So our general nursing care really comes into play looking at problems with ventilation, problems with airway clearance as well, right? So if you're looking at what your outcomes would be, think about what would you want to see in the patient, right? So you don't want them to have respiratory distress. If they had an irregular breathing pattern, you want them to have a regular restoration of a regular breathing pattern, right? We want unlabored respirations. We want normal or improved ABGs. We want decreased oxygen demands, right? We don't want our patients to have to work so hard to breathe. So we do this by looking at a full care plan, right? We assess them, we plan for all these interventions, we do these interventions, and then we assess them, right? We position them, we auscultate their lungs, We sedate them if we have to, and then we look at weaning. So there's so much that goes into breathing patterns and just helping them breathe better. You can do all of those things, but if your airway's not patent, you're not going to get the results that you want, right? So we expect to see a clear and patent airway. We want clear secretions. We want clear lungs, right? So again, we have to encourage cough and deep breathing if they're not intubated, incentive spirometry. We have to suction the patient. We have to humidify the oxygen to thin secretions, right? So those are really important when we look at airway clearance and effective airway clearance. We have to make sure they don't get an infection. They are at risk for pneumonia when you're in the hospital, right? We give patients so much IV fluid. They're at risk for pleural effusions. They're at risk for pneumonia because they don't want to get up. They're tired. They're fatigued. They're not coughing appropriately. They're not using their incentive spirometer. But again, if the patient gets pneumonia in the hospital, this adds a whole nother layer of complexity for them and may not have a good outcome. We need to make sure that patients, we manage their anxiety, right? Respiratory problems are really, really challenging, and they're scary. People come in when they can't breathe; they're afraid of dying. So we have to look at, do they want to be on a ventilator? We have to help them understand that if they do get put on a ventilator, they will be sedated appropriately. So they will be asleep. So we'll manage their pain, we'll manage their anxiety. We want them to have a relaxed posture. We want them to have good interaction with their families. All right. And then we really do want to talk about, we really do need to help families. And part of our nursing care plan has to be helping families understand what's happening with the patient. When you're talking about an ICU type environment, families are frequently there's so much happening inside the ICU itself. Families are not always at the bedside when there's a lot happening. So advocating for what their needs are is really important. If the patient's acutely ill, if the patient's mechanically ventilated, we have to take into account what their wishes are, especially if the patient's young, if this was a traumatic event versus, whether this was an elderly person with a chronic illness. Maybe the family has never seen a patient intubated before. It's very scary in the ICU. There's lines, there's tubes, there's always buzzing and alarms going off. So it can be just a really frightening environment for families. And so it's really important that we have that families talk to each other, that families communicate with the staff and the staff communicate with the family. We want the family to be comfortable asking questions, and we need to be able to answer their questions. So we might need case management involved. We might need social work. Clergy might need to be involved. If the patient's family has concerns, though, say something, okay? Get them the help that they need, especially if the prognosis is poor and this does not look like it's going to have a good outcome and the patient may not survive, and terminal extubation really may be the route that is going to be best for the patient. Families have a hard time coming to terms with that, and that may not be what they expected. So helping families understand what that's going to look like and is just really, really important, okay? So again, just some very general nursing interventions that we're gonna really apply to a variety of situations when you guys are in class. Okay, thanks for listening.